Good morning. I'm Dr. Jim Neininger. This is one of 4 grand rounds sponsored by the Payne Whitney Faculty Council. And today we're delighted to have Dr. Mark Komrad here, who's a psychiatrist and ethicist. He's on the teaching faculty at the Departments of Psychiatry at Johns Hopkins, the University of Maryland, and adjunctively at Tulane. He was an undergraduate at Yale, went to medical school at Duke, and did his residency at Johns Hopkins. He chaired the ethics committee and was the ethicist in residence for Shepard Pratt for over 20 years. He served 6 years on the APA ethics committee and participated in crafting the APA position statement from December 2016, quote, "A psychiatrist should not prescribe or administer any intervention to a non-terminally ill person for the purpose of causing death," unquote. He's traveled widely to address ethical concerns about physician-assisted suicide. He has consulted with policymakers in Canada, trying to dissuade them from extending the current Canadian euthanasia law to include psychiatric patients. He's written a book, You Need Help, a step-by-step plan to convince a loved one to get counseling, and lectures and gives workshops on these topics to mental health advocacy and support organizations. For this work, he was given NAMI's Mental Health Professional of the Year Award. He's appeared frequently on TV, radio, and podcasts, and has consulted with the motion picture industry to help develop more ethical portrayals of psychiatrists in the movies. As a follow-up to today's talk, tonight from 6 to 8 p.m. in Griffith's faculty dining room, he will host a clinical workshop entitled Lessons of History, the Role of Psychiatrists in Eugenics, Forced Sterilization, and the Holocaust. This meeting is informal, refreshments will be provided, and if any of you would like to attend, please see me just after grand rounds. He's particularly interested in meeting with any interested residents. So we're happy to welcome Dr. Comrade, whose talk today is entitled Physician-Assisted Suicide and Euthanasia for Psychiatric Patients, an Emerging Ethical Crisis. Dr. Comrade.
Can you hear me? Here we go. Thank you very much for inviting me. I really appreciate the privilege of sharing with you something that I've really become quite involved in as both a psychiatrist and an ethicist. And we live in very turbulent times, times in which there are rapidly changing social mores, enough to make one vertiginous, if not nauseous. And we see that in a variety of ways, but one of the ways that I'm going to share with you today has to do with not just our idea of what it means to have a good life, which is of course the core interest of philosophers of the ages, but also what it means to have a good death, and the changing concept, the changing fulcrum that balances acceptable and unacceptable suicide, acceptable and unacceptable murder, and very rapidly changing expectations of what society wants from us as a physician. The agenda that I'm going to be pursuing this afternoon, first we're going to start with some basic definitions, then we're going to have a brief history looking back both at ancient times and some near modern times. Then we're going to look at the current picture, the current situations in the United States, Canada, Belgium, and Netherlands and Luxembourg, and a little bit of Switzerland. And then finally I'll make some ethical reflections and remarks. My purpose today is really is inspired by Herman Melville, who wrote in Moby Dick, "Woe to him who seeks to please rather than to appall." And I promise not to please you today, but to appall you, because frankly, you cannot speak about this without a point of view, a point of departure, and as you will see, I have a point of view which I will try to communicate to you, and you can see why perhaps I have been gradually pulled in the direction of being transformed a little bit from being an ethicist into being an activist to oppose some of these developments, although it wouldn't take me long to reveal that to you. So I want to be clear that our topic today is at the intersection of philosophy and medicine and medical ethics, where lies suicide. And Camus reminded us that there is but one truly serious philosophical problem, and that is suicide. And I really do want to emphasize that I think that is our topic today. If you take the simple definition of the CDC, they have defined suicide as death caused by self-directed behavior with an intent to die. This is something that we in psychiatry are familiar with. This is our wheelhouse, indeed our bread and butter, something that we do as one of the core activities that we do, and also, as we will see, I think speaks to the core ethos of what it means to be a psychiatrist and really even a physician. However, there are some groups that want to change that. So remarkably, the American Association of Suicidology has said back in February of last year, legal physician-assisted deaths should not be considered cases of suicide. Many people really rose up against this. It's really quite a remarkable development as we begin to shift the meaning of words. And frankly, the fight for who owns the language in this, much like some similar debates such as abortion, really is sort of the key to what's happening in the trenches. So basically, I, as a professional psychiatrist, clinician, and ethicist, frankly was unaware of what was going on until 2015, when this dropped into my mailbox from the Washington Post. If you were a psychiatrist and a chronically depressed patient told you he wanted to die, what would you do? In Belgium, you might prescribe this vulnerable, desperate person a fatal dose of sodium thiopental. That really confused me, and I found that remarkable, so I had to start digging, and I found some remarkable things, some incredible goings-on in Europe that turns out were hiding in plain sight. And I came across this video, which is on YouTube. I suggest that you all watch it. It's only 35 minutes, but it's done by The Economist, and I've cobbled together a 3-minute montage of it.
I'm Emily, I'm 24 years old, and I'm from Belgium. And this documentary is about my request for euthanasia because of mental suffering. And when you see this documentary, I won't be here anymore.
When it comes to doctor-assisted dying, Belgium has the most liberal laws in the world. This is Emily's story. From the outside, she's a physically healthy young woman with a loving family and friends. It appears Emily has everything to live for, but she finds her life unbearable. In 2013, there were more than 1,800 doctor-assisted deaths in Belgium. While 97% of cases involved people suffering terminal or chronic physical illness, 3% were people suffering psychiatric disorders, the most extreme and controversial form of assisted suicide. Belgium is one of only 2 countries that allow it. Strict criteria have to be met before doctor-assisted death is allowed. Emily's case has to go through dozens of medical professionals and ultimately be signed off by 3 doctors, one of whom is psychiatrist Dr. Euthanasia.
Ik denk dat je nu op dit moment zit je zelf met vragen die je wilt besproken zien.
Voor mezelf de laatste weken is de destructiviteit ook weer serieus toegenomen.
Emily started her application to end her life nearly 2 years ago.
Ik denk dat de meeste, of om niet te zeggen, eigenlijk alle mensen met een euthanasie vragen op basis van psychisch lijden hebben een lang verhaal van psychisch lijden. Dus dat is helemaal verschillend van iemand die een acute depressie doet, bijvoorbeeld naar aanleiding van een rouw. Dat is juist de inschatting van de artsen en de 3 artsen die met de patiënt bezig zijn. En want binnen psychiatrie, de mogelijkheden zijn oneindig. Medicatie, combinatie van medicatie met ambulante residentiële therapie kunnen we verder doen, maar het moeten eerlijke kansen zijn waarvan we echt weten dat het perspectief kan bieden. En bij sommige mensen hebben we die niet, zoals we dat in sommige kankersituaties ook niet meer hebben. Is dat ook zo bij psychisch lijden? Soms hebben we niet meer, niks meer te bieden.
There's several things incorrect about this. She does not have to go through dozens of professionals. Yes, 3 psychiatrists, the 3rd is optional, and they don't all necessarily have to agree with one another. And spoiler alert, This documentary follows her all the way to the moment of her euthanasia when the doctor comes to her house to start the IV, and at the very last minute she relents and pulls back. And as far as I know, she's still alive today, as far as anybody has been able to tell me. So it really appears that being featured in an economist documentary is therapeutic. And taking patients to the brink and allowing them to look over, as many proponents say, is actually a therapy. It is actually something that we ought to be able to provide patients, because many patients, given the option led to that brink, pull themselves back. So I actually missed the memo on this, obviously, until 2015. But I've subsequently been catching up, and catching up vigorously and robustly, and I want to share with you some pieces of what I've learned since then. So let's talk about some definitions that we're going to use. As Humpty Dumpty says, a word means what I want it to mean, nothing more or nothing less. So there are many words that are applied to this, things like physician-assisted suicide, voluntary euthanasia, compassionate assistance to die, physician-assisted dying, medical aid in dying, MAID, that's the term favored in Canada, but in Australia, it's Go Gently Australia, kind of like a laxative. Death with dignity, medical murder, and Kevorkian, of infamy of old, wanted to introduce the term medicide. And in correspondence with that, there's this curious organization, the World Foundation of Right to Die Societies, that is now trying to promote a new term for this, dignicide. Again, trying to own the language. Now, the president of this organization, by the way, I call all of this verbicide. The president of this organization, an oncologist, Rob Pierre, says, I always refrain from using the word killing. You terminate life, and actually more than that, you terminate suffering, and get used to that idea, because it is counter-human a little bit. As indeed it is. George Orwell said, if thought can corrupt language, language can corrupt thought. Many of you would remember these slogans from 1984, war is peace, freedom is slavery, ignorance is strength, trying to introduce some new ones. These days, suicide is treatment, euthanasia is palliative care. My grandkids came to visit. They talked mostly about world politics, kept asking me how I felt about the youth in Asia. So you can twist this every which way. But here are the terminology that's now extant that we're going to use in order of increasing moral complexity. The simplest level is assisted dying, which unfortunately is sometimes confused by calling it passive euthanasia. This is the state of the art in medical ethics, long accepted, actually for many, many centuries, where the physician gets out of the way of death, and now, especially these days, administers very state-of-the-art, effective palliative care to be able to bring about a good death. This could also include the not actually very painful voluntary stopping of eating and drinking, the SED, which many people choose to do with the comfort and help of their medical team as well as their families. So the second level of moral complexity here is called physician-assisted suicide. That is where a doctor writes a prescription that the patient takes to the pharmacy and gets a box of barbiturates and takes the box of barbs at the time and place of his or her own choosing, with or without witnesses, unknown coercion, and if they don't take it, we don't know what happens to those boxes of barbs. Hopefully their suicidal granddaughter doesn't get to it first in the closet. And then the most morally complex is euthanasia, and that refers to a physician actively killing a patient, typically with an IV push of various things that have been used. So the doctor stands at the bedside and produces death. And just to let you know that in the countries that we're talking about outside the United States, this is the predominant practice 99.5% of the time. Other countries allow both 2 and 3, but most people, for reasons that you might want to think about and we can talk about, want to outsource the activity to their physician and choose euthanasia if given the option. As a matter of fact, there were almost no physician-assisted suicides in Canada last year. They were all 100% euthanasia. All right, so we're going to focus mostly on these latter two, But the basic idea here is the patient asks for help to die, and goes, and we call that, and wants to die, and we in psychiatry call that suicidal. Approaches the physician, and the physician creates a treatment plan to produce death, and to actively produce death, to administer to death by an IV injection, or to administer death with a, well, chemical gun that the patient can take home and shoot themselves with at their own plan. So just a little history here that I want to touch on. So in ancient Greece, the mythology was that Medusa, that goddess who could turn you to stone in a glance with snakes for hair, had blood running in each side of her neck. In one side of her neck was a life-giving elixir, and in the other side of her neck, the blood was poisonous. Athena drew blood from Medusa and gave the blood to the Greek god Asclepius, the god of medicine, the god of healing, gave both vials. And throughout ancient Greece, all the ancient Asclepia utilized both vials. Euthanasia was a very common practice in ancient Greece, and the level of therapeutics wasn't that great, with one exception. And that one exception was the Asclepian of Hippocrates. In that Asclepian, not only did they have a more scientific approach to observations and therapeutics, but they made it very, very clear that we are, in this community, actually a community of values. We are a covenantal community. And in fact, when you join, you have to embrace some of those specific values. And the core value, as historians now understand, that distinguished the Hippocratic Asclepian from all the other Asclepia was this value that you recited in the oath that you took. I will not give a fatal drug to anyone if I am asked, neither will I counsel any man to do so. That has been retained till only recently in the Hippocratic Oath for millennia. It has been the soil out of which the covenantal community, the mighty tree of medicine, has grown over the course of centuries, rooted in that, with those values, much like, for example, the tree of Christianity grew out of the teaching and values of one particular group, which was the group that organized itself around Jesus Christ, and still retains those core values to this day. So the House of Medicine is built out of the boards from this tree that date back to this important value covenantal origins. Now, let's just skip ahead for a moment in history. This I'm going to be speaking about more this evening when I'm going to be talking about the role of the leading psychiatrists in eugenics, sterilization, and the Nazi T4 program. But it was actually death with dignity was coined by a psychiatrist, Alfred Hoch, in 1920 in this book, Allowing the Destruction of Life Unworthy of Life. This became Hitler's Bible for the subsequent developments that I will speak more about this evening. But in this book, Hoch wrote, not even the Hippocratic Oath is really binding anymore. The intellectual level of the mentally ill person is that of very low animal life. Such individuals are not just absolutely worthless, but are of negative values, and we doctors know that in the interest of the whole human organism, single, less valuable members have to be abandoned and pushed out. I just wanted to bring your attention to how vulnerable ethics is and how social mores can change and sweep even our profession off its feet. And even without hearing my talk tonight, many of you know what subsequently happened over there, presaged by what happened over here. But more of that tonight if you wish to attend. All right, let's move to the contemporary era. Here's Kevorkian, who said, "To hell with the goddamn ethicists, I'm a real physician." As if those two somehow are divergent sets. So the current situation in the United States, these are the jurisdictions that allow physician-assisted suicide, not euthanasia. You have to be terminally ill, which is what differs from what we'll see shortly in Europe. I just started New Jersey because at the moment New Jersey's law is on hold because there is concern for insufficient protection of those who wish to be conscientious objectors to this. So the judge put a stay on it. We'll hear more about that issue in Canada in a moment. There are actually some states that have inoculated themselves against this and actually passed laws to say, we don't even want you to introduce a bill like that here. So just like with abortion, there are some states that are trying to inoculate themselves. Same thing here. And since 1995, there have been 127 attempts in all 50 states, sometimes up to 8 times, to pass this bill. And with that filter, the 10 jurisdictions that I showed you before eventually got through, many of them after multiple attempts. One thing about all of these laws, and Oregon was the first, and many of them are based on Oregon's, in none of these laws is there any mandatory requirement for a mental health assessment. Most of the assessors are primary care physicians or other kinds of specialists like oncologists. None of them require any mental health training. None of them require any training in capacity evaluation, and the patient has to be considered to be capable of consent. And as the audience here knows, the evaluation for capacity is actually a special skill set that not even all psychiatrists have training in, or at least don't do much, even in our own specialty. By the way, Hawaii says you have to have a mental health assessment one time just to be sure you don't have a mental illness or a capacity problem. It can be done by any mental health professional, social worker, licensed professional counselor. MD is not required. Any physician who signs off can act as a second opinion, even your partner in your private practice. No attempts at palliative care are required. There is no requirement of any witness to verify that there's no coercion, nor are there any standards statutorily or even clearly ethically as to where the line is between helping somebody and pushing somebody and coercing people, and that's not spelled out. There is no minimum length of time of a doctor-patient relationship. So in Oregon, relationships as short as 2 days, where the physician is new to the patient, have been documented. Patients can refuse treatment to convert themselves to be terminally ill. Remember, these laws require you to be terminally ill. A patient can refuse dialysis, a patient can refuse insulin, a patient can refuse chemotherapy, and convert themselves from a non-terminal illness to a terminal condition, thereby becoming eligible for these laws. And you might say, well, under certain circumstances, wouldn't an ethical physician refuse to write the prescription for assisted suicide? And I would say, yes, if there were unethical physicians, and I hope that most of us are, but there are some who are making a specialty and making their living. In fact, 3/4 of the prescriptions that were written in Oregon are written by 10 physicians. By the way, there are pushes now to move in these 3 states. I'm not going to go into them in detail, just to mention the headline, that there are pushes now to move because there is, as I'm going to prove to you this morning, an inevitable slippery slope, not a theoretical slippery slope. The data is clear. Already 3 of these states have been pushing towards moving from assisted suicide, where you write a prescription, to euthanasia for people that are too impaired to be able to administer themselves a box of barbs. And they're pushing for physicians to be able to do it by needle, or certainly to have friends open their mouths and drop in the barbiturates. Just a little bit, a moment more on Oregon. This shows you the number of total scripts that were written and what's been used. In contrast, over this time, about 10% are under 55. 6 patients, despite all these barbiturates, failed to die. 1 took up to 4 days to die in considerable agony. And because it's not required by law, in the vast majority of cases, no physician is present to monitor, to help, to rescue, and to help make a good and comfortable death that's supposed to happen with this. So you can see that of over 2,200 scripts dispensed, about a third or a quarter of them were unused. And the question is, what happens to those medications? Where are they? Where are those boxes of barbs? The fact of the matter is, we do not know. In one particular case, the pills sat around for 807 days between being dispensed and being used. Fortunately, they didn't find themselves diverted, but there's no law that says after a certain number of days you got to bring this stuff back to the pharmacy. So this study looked at the primary reasons, because patients are asked, surveys, why do you want to do that? And the medical records were reviewed in both Oregon and Washington, and the primary reasons were fear that a patient had in the future of losing autonomy, inability to engage in their activities, loss of dignity, being a burden to the family. The minority were asking for it because I'm in pain right now. It was all fear of the future. And again, this certainly is our wheelhouse, isn't it? Fear, dealing with fear, dealing with anxiety, helping people with existential crisis, independent of the diagnosis, by the way. This is in our skill set, and yet we as psychiatrists have not been formally invited into the party. Indeed, Mr. Montagna said, he who fears he shall suffer already suffers what he fears. Because initially, when Oregon first got started, and again, it's optional, I think maybe they should see a psychiatrist, when the first year it got started, 1/3 of cases were referred to psychiatrists for help, evaluation, maybe dissuading people, I don't know, but for whatever it is that we can do. But as you see, as the years have gone on, it's dropped off considerably, and now almost no patients are referred to psychiatrists. And yet, and I skipped this slide, there's data to show that up to 30% of the people who have been given their box of barbs and have not yet used it, when you go to interview them, one out of 3 have clinically significant, they have bona fide major depression that could be treated with a variety of techniques. By the way, when you offer them treatment, only 1 out of 20 said, sure, I'll take treatment. Offered for free, by the way. Everybody else had made their decision. They don't want psychiatrists. All right, let's talk about Canada. In Canada, as I said before, it's predominantly euthanasia. In 2014, there was a lot of discussion of going in this direction, and the Canadian Medical Association decided to soften its stance that had previously been against this. The softening of stance by medical societies is almost always a prelude to legalization of these activities. So what Canada did is they decided to get out of the discussion, or at least partially out of the discussion, of whether people should be terminal or non-terminally ill. And instead, in 2016, they passed a federal law that permitted euthanasia with a unique language that's only found in Canada, and that is death in the reasonably foreseeable future, which is supposed to be towards the end of life, but it is not statutorily defined. The statute says nothing whatsoever about the length of prognosis, just this vague statement, death in the foreseeable future. It has been felt to apply mostly to people towards the end of life in practice, although there are people who have been euthanized who have a 4-year prognosis, a 6-year prognosis until death. Instead, they have taken the European model, as we shall see, about conditions that it's more about suffering, that the conditions be intolerable to the patient and untreatable. But the patient gets to weigh in on both. The patient, of course, only the patient can say, I can't stand it. But also, the patient gets to weigh in on it being untreatable, because the patient, inconsistent with the standard of contemporary medical ethics, can refuse treatments. They don't have to be forced to take treatments. Right now, under these conditions, psychiatric patients are not yet allowed. So this has taken off in Canada. There was a 50% increase just between 2017 and 18, when there were over 4,000 euthanasias nationwide in Canada. Now, I told you about this death in the foreseeable, and that, for people watching the psychiatric situation, has been the barrier that has prevented, or at least somewhat fortified, the safety of our patients not being included. However, on September 11th, an auspicious date in the calendar every year, but now made further so, a Quebec court ruled in a particular case, Truchon case, that the death in the foreseeable future is not an appropriate standard, that it cannot stand up to the scrutiny of justice and fairness and parity, and said that that is invalid. And as a result, because it was the Supreme Court of Quebec, sorry, Ontario, Quebec, Supreme Court of Quebec, this now gets, the way the Canadian system works, it is now incumbent upon Parliament to go back to their law and reconsider whether or not they're going to change it. There was much expectation that Justin Trudeau was going to favor making that change, because he favors the further liberalization of euthanasia in Canada. As he said right after this case, we will not appeal the decision. The law, the euthanasia law, was purposely designed to be restrictive initially, but we understand society evolves. And as you know, he just won the election. So indeed, we may be seeing now this very significant change in Canada. Now, there are many places, such as the British Columbia Civil Liberties Association, that are pushing to include psychiatric patients under our most sacred tropes: parity, non-discrimination, anti-stigma. Psychiatric illnesses shouldn't be considered any different than medical illnesses. So organizations like that, Dying with Dignity in Canada, and a variety of other organizations are out there pounding on the doors of the courts and of the legislatures to open it up to psychiatric patients. Here's the Alzheimer's Society. Another type of psychiatric patients are people with dementia that currently are excluded because they don't have capacity. And this, which is their version of the Alzheimer's Association in Canada, has now just recently declared that they now support opening euthanasia to people with dementia. And this is the head of the Canadian Association of MAID Assessors and Providers, Dr. Stephanie Green. And she says, "I'm really proud of what I do. It has brought richness to my life. There's an art to it. It feels great." This actually takes a toll on a lot of physicians, and a lot of physicians are pulled out of it because it takes a toll. It's particularly poignant to find somebody who says, "It feels great." I call it this euthanasia 2.0. Once the camel's nose is in the door, I want you to see what happens. Having established that, the Ontario the College of Physicians and Surgeons has declared that you cannot be a complete conscientious objector. Of course, you don't have to euthanize anybody, but many people who are against this have said, "I don't even want to refer anybody because I'm part of the chain of referral." Back in the day of the Nazis, for example, pointing to the window where the Jew was hiding was being part of the chain of culpability. So they don't want to be part of that chain. Their medical society said, "No, you must be part." Because the medical society said that, the conscientious objectors took this to court, and the court upheld what the medical society said. And the court said, since your medical society says it's okay, you can't stand on medical ethics with your objection. If you are objecting, you must be religious. There must be a religious point of view, and religion has no place in medicine and no place in our Constitution, which they call the Charter. So now, being a total conscientious objector is neither ethical nor legal. And that's really important. Because now, if you're a conscientious objector, you must, number one, have a discussion with patient, informed consent, telling them, "Oh, an option is euthanasia. I need to tell you that." And you can't step out of the way and say, "But I'm not going to refer you to anybody. I won't do it myself, but I have to find you somebody at least might be willing to do it." So that's the state. The president of the Saskatchewan College of Physicians and Surgeons says if doctors have conscientious objections, maybe they shouldn't be doctors. There's even talk now of speaking to medical school applicants, asking them, "Do you have a problem with this?" as part of the medical school interview, to possibly screen out or at least dissuade those people that maybe medicine isn't for you. The head of the College of Physicians and Surgeons in Ontario, the one that struck that ethical point that I just made, said there are a number of areas in which physicians are unlikely to encounter MAID, to which they could transfer. and which may not require specialty training and certification, where you go into it in the first place. And you can go into pathology and deal with the dead afterwards, rather than produce it. So look at this cartoon. Suicide prevention program on the right, assisted suicide on the left. Man in a wheelchair, notice which side the ramp is on. This ethicist says the distinction between whether death is hastened by a medical professional or by the suffering person is becoming essentially meaningless and irrelevant in Canada. He's in Alberta. So we see here that there is a change in this fulcrum on which balances what's acceptable and unacceptable suicide and murder. In this particular article in 2017, this physician ethicist said, if MAID for mental health for psychiatric patients is allowed, the goal in the emergency room might be to shift to first deciding whether the patient's eligible to request and capable for consent for MAID. So, let's first, because we now have that option, we have suicide we can provide to the patient. And indeed, here is evidence that, in fact, since MAID has become legalized, that doctors are starting to interpret many suicide attempts as an implicit refusal of treatment and are beginning to talk to patients about aid, especially if they're medically eligible, and sending them home. So again, it's changing that balance. And in terms of murder, here's a guy who sought euthanasia for his wife and was told that she didn't qualify. And he said, well, look, we live in a country where people can, lives can be taken under certain circumstances. I don't think the medical profession is right in this decision about my wife. I'll do it myself. And he murdered her, utilizing MAID as a way of thinking. Again, a change in the cultural balance, which we will see. All right, now let's cross the Atlantic and look at the living laboratories of Benelux, Belgium, Luxembourg, and the Netherlands, where there's some very critical data to mine. So in 2002, all three of these countries decided to completely efface any differences between terminal and non-terminal conditions. Also, they did something which we probably would applaud in psychiatry, have been pushing for. They've effaced the differences between physical and mental suffering. Suffering is suffering is suffering, right? So instead, what they did is they replaced it by the standards of unbearable conditions and untreatable conditions. And remember, I told you that patients have a right to refuse treatment, so untreatable is decided as much by the patient as by the medical team. So any kind of suffering that's unbearable and untreatable became eligible for euthanasia. This opened it up to psychiatric patients. It opened up to children in the Netherlands older than 12, Belgium no lower age limit, and they opened it up to advanced directives so that you can decide years in advance, if I become irreversibly mentally incompetent, I'm saying now that I want euthanasia then. So let's take a look at the Netherlands first. So here is the evolution of euthanasia. They reached nearly 7,000 cases in the last couple of years, so 13,000 cases in the last 2 years, a 350% increase over the first year. Now, about 5 out of every 100 human beings who die in the Netherlands die at the sharp end of a physician's needle. Deliberately. Physicians are responsible for the direct killing of 5 out of every 100 people now in the Netherlands. And this may be underreported according to this article in the New England Journal. So what about psychiatric euthanasias? In terms of non-dementia, there's been a considerable growth of that over the course, it's between 70 and 100. It backed off a little bit in 2018 because of controversies, but about 1 a week. Now, if you want to, I've separated out dementia. Dementia is a much more popular cause. Remember, you have advanced directives in these countries, so it's possible you don't have to have capacity at the time like you do in Canada. So there are two methods, two possible directions you can go. One is to work with your own doctor, to have your own doctor evaluate euthanize you, or you can go to one of the so-called end-of-life clinics. And both those will result, if you properly qualify, in euthanasia. The end-of-life clinic, the Lebensende clinic, only recently has been renamed as they felt that was something they needed a little bit more focus, euthanasia expertise centers. The purpose of the end-of-life clinic is to get out of the whole conscientious objection dilemma that Canada finds itself in by saying, look, if your doctor doesn't do it, you can go to this specialized center where we'll evaluate you. So let's look at these two routes. So here is one study of people by their own physicians, 2011 to 2014. You can see the array of different diagnoses there of the patients, mostly mood disorders. But over half had either separately or comorbidly a personality disorder. And I don't have to tell this audience what's the most likely personality disorder that they have. Now, over half refused one or more treatment recommendations, medications, ECT, as they are allowed to. You ask them why, and they're the common reasons why our patients sometimes refuse treatments. No motivation, concern for side effects, doubt about efficacy, all the things that are daily fare. 28% of the people with personality disorders had no history of any psychotherapy. Scott Kim, who gathers a lot of this data, my colleague at NIMH, just published this paper earlier this year, no psychotherapy for people with personality disorders prior to euthanasia, because they can refuse it. They can refuse it. No data as to why they either weren't referred or they refused. We don't have that data. In terms of how intensely were these people treated, almost a third of them had never had inpatient treatment. Only 38% had ECT at one point. Another barometer, of medication that isn't often reserved for treatment-resistant cases. Only 11% had an MAO inhibitor. 66% said their primary motivation for this, the reason they wanted this, is social isolation and loneliness. Is that not endemic to the population that we're used to working with? 24% of the time, 1 out of 4 times, the independent consultants disagreed with one another, but euthanasia proceeded anyway, which is allowed. The independent consultant doesn't have to agree. And half of those independent consultants were psychiatrists. By the way, it's not always a psychiatrist who's the independent consultant on a psychiatric case. That's recommended, but not required by Belgian law. And 73% were euthanized by their own treating psychiatrist. The same doctor who had been trying to prevent their suicide heretofore basically succumbed to, the projective identification, to the hopelessness, to the pressures that patients put upon us, and flipped and decided that they would provide the suicide personally, or agree with the remainder to send them over to the Euthanasia Expertise Center. So the amount of euthanasias that have been going on there have been climbing. It's increasingly popular. In 2016, I don't have data for later than that, the majority of psychiatric euthanasias occurred in these clinics. And these clinics are traveling teams. There are 60 of them. They typically evaluate a patient between 1 and 1.5 hours in that evaluation. And usually the physician is new to the patient. There is no requirement that physician call the treating physician. That's a good idea. It's recommended, but there's no statutory requirement that you call the treating physicians and say, hey, tell me more about this case. So a former proponent of euthanasia, now turned against it in Netherlands, said, within these clinics, a group culture has emerged in which euthanasia is considered to be virtuous labor, especially for severe dementia and chronic psychiatric conditions. So there's a groupthink that's going on there. Now, it gets even more remarkable. The Minister of Health and the Minister of Justice, along with the most dominant political party, are pushing to actually go beyond medical indications, to be able to make euthanasia available for people who feel they've had a completed life or are tired of living. In fact, the head of the D66 party said, we have to take it step by step. In 2002, we passed the euthanasia law for unbearable suffering. We can now take the next step for our civilization. And in fact, that's exactly what they're doing. Still, as recently as September, they're going to press ahead with the Completed Lives Initiative in Parliament. So, moreover, and this makes me slightly 1 nanogram more comfortable as a physician, they want to take it out of the House of Medicine and develop an over-the-counter suicide bill. This is very popular. 46% of people in the Netherlands want this. There's a large organization called the Dutch Voluntary Euthanasia Organization that is pushing for this. That's one of their main agendas. In fact, they put on every year, a week of euthanasia, a festival of euthanasia. And they have all sorts of workshops, including a workshop for the virtue opportunity of donating your organs as part of euthanasia, which is allowed in that country and is now being allowed in Canada. They're even in Canada discussing getting rid of the dead donor rule so that people can have live organ harvesting in the moment of euthanasia, so to be euthanized by organ donation voluntarily on request. But, they have this thing, do you have a death wish? So I was involved with a documentary that went to this week of euthanasia and found that the majority of people there were psych patients. Psych patients who feel like the law is too restrictive for them. Yes, you can have psych euthanasia, but it's so difficult to get approved. I mean, after all, we only have less than 100 people a year. If we were doing this right, we'd have 1,000 people, psychiatric patients a year being done. So they're advocating for this. And of course, by the way, they're very attracted to this seminar on organ donation because, after all, who are those eligible candidates for organ donation? Young patients like Emily, psychiatric patients with good organs, and who can be the most seduced by the idea of making virtue of the adversity of your terrible suffering failed life. You can imagine how, for example, people with borderline disorder might be quite vulnerable to that kind of seduction. Here's a study that just came out in April looking at the experience of 22 doctors in the Netherlands who performed euthanasia, and it talks about all of the vicissitudes of being in that position. Emotional blackmail by patients, control and direction by others, tremendous doubts about whether people really fulfill the criteria, a lot of counter pressure from patients' relatives to not do it, time pressure about referred patients not having enough time to really think these things through, and organizational pressure to go ahead with it from the organization. Let's look at Belgium. So this is the situation in Belgium. 550% increase. In the Flanders region, 6 out of every 100 people who die by a euthanasia needle wielded by a physician, although not always a physician, as I'll show you, even though it's supposed to be. Maybe even more lower accuracy here, since many as 40% are maybe unreported according to this New England Journal article. Here are the psychiatric cases. You can see it's kind of similar numbers to what we saw in Belgium. The majority were women. You can think about and speculate about why that might be and what might be the factors, both psychological and sociological, about that. So here is one run of patients, 124 patients. Between these years, you can see some of the diagnoses here. Dementia, obviously the most, but depression and, of course, borderline personality disorder. You saw Dr. Thienpont in the film. I am a pioneer. I am so loved and hated. She is the psychiatric Kevorkian of Belgium. Wrote this book, Libera Me, Free Me, on the euthanasia and psychological suffering. Fascinating thing is some of the physiognomic similarities between Kevorkian and Thienpont. I'm really kind of spooked by that. Anyhow, here is her report on her first 100 patients. She found them all competent, despite the fact that 14 were psychotic. That kind of beggars belief, in a way. And of those 100, she accepted half of them for euthanasia. And by the time this patient had written, of those half, 73% went ahead with the euthanasia at home or in a clinic, as I described to you before. The rest we don't know about them. A couple of them died, one from anorexia. So here is the distribution of cases that she saw. And major depression, and again, just like in the Netherlands, personality disorder, of which half were people with the construct borderline disorder as fitting their clinical condition. So they're a very large subset of the population that's being euthanized. We're told, especially these days, not to diagnose anybody from TV. But certainly the astute clinical mind might be thinking about this construct for Emily from just a brief interview that we saw there. So basically, here's how the slope is slipping there. A pair of twins going blind, they were accepted for euthanasia and received it. A man with ego-dystonic homosexuality, accepted, euthanized. A person who's had multiple surgeries for gender reassignment without satisfactory results, for him, euthanized on request. Indeed, a prisoner said, I have an insufferable condition. I'm in prison for the rest of my life for rape, and it's intolerable to me, and it's untreatable because I have a life sentence without the possibility of parole. He was accepted for euthanasia until word leaked out, and a number of people protested, and that was rescinded. Indeed, you might think that some of the least likely to perform euthanasia are the Catholics. And indeed, the Catholics in Belgium run the majority of psychiatric facilities. They have 5,000 beds in Belgium. They're the Brothers of Charity, and their mission is, for a couple of hundred years, has been treating people with mental illness. So they, for 15 years, said, not in our facilities, not going to do euthanasia here. But ultimately, the society is so besotted with this in Belgium that it percolated into the Catholic domain and the leaders of the healthcare arm of the Brothers of Charity. And in 2017, they said, okay, we will have eligibility for euthanasia and perform it in our Catholic institutions. The Pope said, no, you're not. He said, euthanasia hides behind alleged compassion to justify killing a patient. The dignity of human life is at stake. Nothing must prevent you from putting more heart into your hands. Well, the head of the secular head of the Brothers of Charity, who was also the former Prime Minister of Belgium and the first Prime Minister of the European Union, Herman van Rompuy, responded, the time of Roma locuta causa finita is long past. In other words, we used to say in Catholicism, Rome has spoken, end of conversation, let's move on. He says that time has passed. To this moment, the brothers have remained open to euthanasia. They haven't done one yet, but their policy remains open to it, and the Catholic Church is trying to ask them to dissociate their facilities from Catholicism. So that's quite a controversy that's brewing. I actually had the privilege of speaking to the whole board of directors right on the over there in Brussels, right as they were about to respond to the Pope, and I thought, I helped to try to convince them to turn it around, but unfortunately my one attempted international political intervention failed, and they still retain that position. So in Belgium, it's illegal for nurses to perform euthanasia, and yet, here's a survey of over 1,600, in 12% of euthanasias, the nurses administered it. And indeed, since there are, and I don't have time to get into this, many euthanasias without consent, so-called mercy killings, actually quite a few, in those cases, almost half of them are actually being done by nurses, not by doctors. And that's not legal. The authors of the study said the nurses operated beyond the legal margins of their profession. Now, to talk about the way in which it changes culture. Remember, we talked about that in Canada, about the fulcrum between what's acceptable and unacceptable, and a changing attitude towards death and healthcare. Now, 40% of all Belgians say that people over the age 85 should not have any kind of life-sustaining treatment. They can have ameliorative treatment, but not life-sustaining treatment. Because we have euthanasia now. So that's a different option. This is an opinion poll, 2 independent opinion polls. So it was reproduced. This isn't a one-off thing. Just a moment in Switzerland, because as many of you know, Switzerland is the only country that allows medical tourism for euthanasia, and you've read about people, famous people going over there for their euthanasia. And it's actually been since 1992. But basically, it's not administered by the profession of medicine or in mainstream medicine, but clinics are allowed to do it with the government deciding they're just not going to prosecute it. And the Exit organization is one of them, and they're one of the people that are promoting the idea that it's actually an effective form of suicide prevention. Living in the certain knowledge of a way out has motivated more than half of the people originally intent on dying to keep enduring their painful lot until they pass the natural way. By the way, no mention of palliative care there. So the vice president, here's something hot off the press of this organization. This is from last week. Was prosecuted for euthanizing an 86-year-old woman who wasn't sick. Her husband was dying. She wanted to die with him. So she met no criteria that the Swiss government has established, which are not dissimilar from what I've been talking about in other countries. She just wanted to go with her husband, and he did that. He was prosecuted but given a suspended sentence of 120 days. I think the word days somehow got dropped off there. 120 days, but suspended. So that's sending a message. And by the way, there have been several cases now in Canada of people euthanized who were well, otherwise wouldn't meet the criteria, but their spouse was either being euthanized at that time or about to die at that time or had just died. Those cases have not come to prosecution in Canada. So, ladies and gentlemen, here's the way the slope slips. Starts with the terminally ill, and inevitably, in every country that has had this for a while, it precesses to the non-terminal by virtue of the usual principles of justice and fairness and parity. And then the distinctions between physical and mental suffering are effaced, as we probably would want them to be, and those with mental suffering become eligible who are non-terminally ill. That's our patient population in general. Children become eligible. Places that have only, like in those US states, only physicians-assisted suicide push for a variety of reasons towards euthanasia. Then advanced directives become allowed. Then mandated referral by conscientious objectors. Then we see people with major mental illness get in line, and then people with minor mental illness and uncomfortable lifestyles, alcoholism, egotistonic homosexuality, then prisoners with life sentences, as I showed you, then doctor-only or nurse-only mercy killing. Then they open to euthanasia tourism, inclusion of healthy spouses, pushing for legislation to demedicalize it and have completed life. We're tired of living criteria, have reduced medical care for the elderly, and then the desire for the over-the-counter suicide pill to allow people to commit rational suicide, and we finally get to the SARCO. What's the SARCO, you may ask? Stand by for the SARCO. I'll tell you shortly. All right, a few ethical comments. The way I see it, unethical ethics are better than no ethics at all. So, the Holocaust was legal. Slavery was legal at one time. Hiding Jews was criminal. Freeing slaves was criminal at one time. So the point is that legality is not morality. Benjamin Rush, founder of the APA, one of our psychiatric cultural heroes, said the Constitution of the Republic should make a special privilege for medicine's freedom as well as religion's freedom. Why? Because he recognized that medicine has its ethos that we have carried with it and developed with deep thought, with a venerable tradition, now with intense modern scholarship and really due consideration. And we come with our own set of values, and those values travel through history and retain a coherence as it goes through society after society that rises and falls. and asks many things of us, some of which we are congruent with, and some of which really are against what that core ethos is as we travel that historic trajectory. So, preserving that legacy are some of the most important bodies of organized medicine that evince ethical codes, such as the World Medical Association, that continues to say that physician suicide and euthanasia must be condemned by the medical profession, and a physician who does it acts unethically. The AMA has now 3 times had this challenge, that it is fundamentally incompatible with the physician's role as a healer. Similar language. 3 times has that been challenged, and 3 times in deep study, the Committee on Ethics and Judicial Affairs, which has invited people to come and testify, and scholars, and spend 2 years studying this, with 3 successive challenges, has decided to sustain and retain this language. The American College of Physicians, same thing on the basis of substantive ethics, does not support legalization of physician-assisted suicide. And, as you may have heard in my introduction, because I was very instrumental in bringing this about, the American Psychiatric Association stands with the AMA in all things ethical, which means that our APA also is with the AMA being against it all. But I felt, and some of my colleagues felt, that with the goings-on that I've just described to you in Belgium and Luxembourg and elsewhere, Switzerland, that we needed to send a specific message to the psychiatrists, especially over there. And so we crafted this position statement in the Assembly, which I'm a member of, and ultimately passed unanimously, very rare for the APA Assembly, and went to the Board of Trustees on December 10th, was approved that the APA, in concert with the AMA, holds that a psychiatrist should not prescribe or administer any intervention to a non-terminally ill person for the purpose of causing death. Non-terminally ill, those are the category of our people. Notice we have a larger category than just psychic patients. And we wanted to make this special statement to send a shot across the Atlantic to those countries, which, when we did, aroused a great deal of response. And I myself became quite a controversial figure for a while in those countries, because I was associated with this. Very glad to be a controversial figure in those countries. So the old paradigm, the whole ruling paradigm of Western civilization has been heretofore the sanctity of life, on which many, many religions and ethical codes are based, including is at the core of our medical ethics. But the new apotheosis here has become autonomy, which has come to trump, am I allowed to use that word? Trump the sanctity of life as the dominant point, that patients have that autonomy of self-determination. Charles Foster at Oxford said, autonomy grew up as a street fighter and was bloodied in some genuinely noble battles against the medical paternalism. But, like so many rulers with this sort of pedigree, it has quickly forgotten its democratic roots and grown fat and brutal in power. Because there are many other considerations that are very important both in social policy and in medical ethics. Fairness, non-maleficence, suicide prevention, the common good, beneficence, and indeed still the sanctity of life. These are all part of the conversation. And as Chabot said, autonomy has derailed and crashed into many of those other considerations, because in point of fact, it's pseudo-autonomy, isn't it? It's not the patient that decides whether the assisted suicide or euthanasia is going to take place. It's the doctor. We are still the individual who decides whether or not a condition is untreatable, unbearable. His is unbearable, hers is not. I can think he can take it, she can't take it. It's still up to us. So it's a pseudo-autonomy paradigm. As the most solemn and consequential intervention a physician can be asked to make, the decision to kill is oddly contingent on a single mercurial human conscience. So there is still a lot of push to deploy the principles of parity and fairness with regard to our patients. Because fundamentally, here's the issue. If we are going to say physical and mental suffering are not distinct, that suffering is suffering is suffering, which is what's happening in Europe, what's happening in Canada, and I can guarantee you with the current trend in the United States will eventually evolve here in the United States because it makes a certain degree of sense. That's the platform, the foundation on which assisted suicide, physician-assisted suicide, and euthanasia are built. But if that's the platform, then considerations of whether a person is terminal or untreatable or has capacity or has somatic conditions become much less important. Because in all of those situations, suffering can still exist. And if suffering and its associated autonomy, although capacity challenges that, are the ruling principles, then this opens things up to things like involuntary euthanasia for the poor suffering people that can't decide for themselves, the completed life paradigm, non-terminal patients, and psychiatric patients. Now, in our field, of course, prognosis is based on diagnosis, and you know how squirrely our diagnoses are. They're phenomenological. There's no other domain of validation. There's a tremendous amount of comorbidity, and even if we can agree on what the diagnosis is, it's very difficult in our patients to predict prognosis. And there's so many treatment options that are available in our field, and many of those treatment options, even in countries with socialized medicine, are not readily available to people, either because of inaccessibility, shortage of manpower, inability to fund them and pay for them. I mean, there was a whole article in the American Journal from Holland that showed that it was harder to get somebody approved for vagal nerve stimulation as a treatment-resistant depression intervention than it was to get euthanasia approved. So before we try assisted suicide, Mrs. Rose, let's give the aspirin a chance. Countertransference is obviously an issue that is a familiar point to this audience. Glenn Gabbard said, decisions made by medical professionals, including psychiatrists, can never be entirely free of what we would broadly call countertransference issues. The doctor's own anxiety in the face of death, and even the hatred of the patient who doesn't want treatment or will not allow the doctor to be helpful, can influence a supposedly scientific and rational decision in this pseudo-autonomy paradigm that we have. Suicide contagion is something that's now being studied. We see there's a 20% increase in unassisted suicides in the Netherlands, much larger than in the surrounding countries with similar demographics, don't have euthanasia. In Switzerland, there's been a tripling of unassisted suicide in women over 65 and a doubling of unassisted suicide in men. So changing the threshold and making the point that, yes, there are some people for whom suicide is acceptable and legitimate. The question that we're now beginning to worry about is how does this change the zeitgeist, change the overall atmosphere of what the idea of suicide being acceptable. Acceptable for some. Well, if it's acceptable for them, it's acceptable for me. So as a result, you have this change in the fulcrum, and as a result, in order to make it more acceptable, patients are wanting to outsource suicide. And the fact of the matter is, and to medicalize it and put it into the hands of physicians to be able to provide it. And yet I submit to you that there is some value in suicide prevention for retaining a taboo against suicide. For putting the moral responsibility for suicide, even though, yes, you're ill, and yes, your autonomy is reduced, and all the reasons why, suicide is an irrational decision, and yet, still, fundamentally, the moral responsibility for suicide has heretofore lay in the hands of the person who attempts suicide. But outsourcing it to medicine changes that, and I think removes in the overall conversation about suicide an important restraint. Even though we can have moral taboo with suicide without stigma, and I think that is possible. Tricky, but possible. The idea it's not good to commit suicide, it's not okay, is an important message that we have to continue to promulgate. So the difference between a freedom and a right. A freedom is something that you cannot interfere with. There's a freedom to own private property. The The government can interfere with that, maybe certain special circumstances, but the government is entitled to give you property. There's a freedom to drive and get a driver's license, but the government isn't required to give you a car. So freedom are liberties you can't interfere with, and rights are entitlements to resources and privileges. So heretofore, freedom has been, suicide has been a freedom. And what these laws and trends are doing is transforming suicide from a freedom into a right. And whenever you have a right, there is a duty associated with that right in a society, in a government. So the question is, whose duty is it? Is it the physician's duty? And I submit to you, no, it is not our duty. That we can indeed retain, express, and promulgate values in this covenantal community of what we are, and say who we are and what we do. It is not our duty. So the question is, if it's going to be a right, whose duty is it? And I submit to you that if the government wants to make it a right, it's the government's duty to provide that. Here is Saint-Saëns, who was the 5th generation of royal executioners in France. And the term laicide, get it out of the house of medicine. Because there's something critically important about keeping the roles of bringer of comfort and bringer of death separate, even if they're arguably on a conceptual continuum. So here comes the Sarko. Philip Nietzsche, who is an oncologist in Australia, has invented this device which can be 3D printed. It is a device which, when you enter it and close the lid, floods the chamber with nitrogen so that you very gently and gradually asphyxiate. You bring a caddy with you, body caddy, to make sure that your body can be disposed of. How do you get access to the Sarko? You take an online test. The online test, by the way, doesn't care whether you have depression or not. Doesn't even ask you about that. All it does is, with an online test, the computer decides if you have capacity. And if you have capacity, you're given the code to your nearest Sarko. So this takes it out of that. This is one way of taking it out of the house of medicine. This is one form of laicide. This is taking the moral outsourcing back from the physician and giving it to the patient. I don't approve of this. I don't want this. I hope that it's not produced on a widespread basis, and I hope that the people who are thinking about using it come knocking on my door first, so that allow me to do my thing, because my thing is founded in the fundamental ethos of psychiatry, which this turns on its head, about who we are and what we do. We are the profession that prevent suicide. That is our core mission. That is fundamental to how we envision the nature of what we're trying to achieve with the patient. We try to ameliorate suffering as best we can, utilizing the interventions that we have available. We try to help the people understand the context of that suffering. We try to fortify their support systems, advocate for them, to try to get resources. We can even have the capacity, again, independent of diagnosis, to make meaning of unresolved suffering of patients. That we know how to take the journey of compassion, which means to suffer with. Believe me, we psychiatrists are probably more experienced and skilled than almost every other specialty of medicine in listening, spending time, and being present to these patients. We prevent suicide, not provide it. And indeed, here are two evidence-based therapies, dignity therapy and meaning-centered therapy, that have been looked at for people at the end of life that are extremely effective, if applied, at helping people change their thinking about wanting to have assisted suicide or euthanasia. Just as the Pope should not perform abortions and the Dalai Lama should not take up arms, a psychiatrist should not counsel or abet suicide, for in doing so, we have misunderstood and betrayed our vocation and profession. Validation of suicide or assisted suicide by psychiatrists is therapeutic and professional hypocrisy. My mentor at Johns Hopkins, Paul McHugh, back in the Kevorkian days, wrote, patients are seduced by isolating them, sustaining their despair, revoking alternatives, stressing examples of others, choosing to die and sweetening the deadly poison by speaking of death with dignity. If if even psychiatrists succumb to this complicity with death, what can be expected of the lay public? As your own version of the Hippocratic Oath here at Weill Cornell says, I will not withdraw from my patients in their time of need. I will suffer with them. And in the words of Winston Churchill, I will say, never give up, never give up, never, 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 never. Thank you. I think we have some time for questions or remarks, reflections. Yes, sir.
Just to point out, meaning-centered psychotherapy, I'm coming from Sloan Kettering. There's no evidence that meaning-centered psychotherapy reduces suicidality. It might increase some sense of meaning and purpose. My experience is that, and this, I guess, the core issue they bring up, that it's a time-limited therapy. I think you beg the question that fear is under the purview of psychiatrists, which I'm not sure about myself. I don't think of it as pathological. My job would have been much easier if I could guarantee my patients that they get 24/7 home care, nursing care, preserved their autonomy and dignity, that they could get weekly psychotherapy. It's impossible to give psychotherapy, to easily connect people to that here in the city. To be able to guarantee that they'll have more than 10 minutes with their oncologist to talk to about the problem. So I get that there needs to be a firewall. There's such potential for abuse, and we don't want to say because it's too hard, we're going to go to the path of least resistance. But I don't really see where we're offering the other elixir, where we can confidently tell our patients that we have treatments for your fear, we have ways of alleviating your fear.
Yeah, I think those are very important points. So let me respond to both of them. Number one, I think that it is incumbent upon us, if the system is broken, to mobilize our efforts to try and fix that system, improve that system, and not try to find ethically questionable shortcuts and workarounds in the face of the inaccessibilities of that system. And it's very frustrating, I understand that. And the question is, what should we be devoting ourselves to, our time, our energy, our purposes, to our patients in fixing the system? So I don't think that saying we can't get what we need, therefore let's short circuit and provide assisted suicide and euthanasia. I don't think that that is an appropriate way of coping with that kind of frustration, both as individuals, but especially as professions and as societies. You know, I want to turn not just to the people at Sloan Kettering to get more access to these kinds of interventions for patients. But by the way, some of these things don't have to be done by psychiatrists. And as a matter of fact, there's a tremendous amount of research on. My wife is a clergywoman, and she is a volunteer hospice. And so there's a whole literature on the incredible value of hospice volunteers for people at the end of their life, to be able to give them comfort and meaning, and actually to turn around some of their thoughts about, you know, wanting to have some instrumental agent come and hasten their death, as opposed to, you know, perhaps refusing treatment and allowing the process to occur. So volunteers is important, and other family, you know, mobilizing family to come in is important. But to speak to whole systems, to speak to policymakers, to speak about, you know, making parity better and funding better for these kinds of things, both professionally with psychiatrists and hospice volunteers and so forth. The other thing I want to say is I want to reject the idea that a psychiatrist's role must, in the engagement of the patient, stick strictly to those things that can be commonly agreed upon are pathology, that are psychopathology. I think if any of you are sitting with patients, I dare say that the majority of the conversation that you're having with the patient about what's going on in their lives, what they're struggling with, and so forth, is not necessarily focused on or referenced with, or even necessarily an epiphenomenon of the patient's psychopathology. Patients bring to us, at least if you have the time to do this, which gets back to resources. But certainly if I can think about my own practice in psychiatry, I have much to say and help and discuss and hear from my patients about various things that are relevant to how they are coping without necessarily limiting the conversation to how's your mood on a scale of 1 to 10? Are you moving your bowels? Are you having insomnia? Are you having dry mouth? Are you having any suicidal thoughts? Okay, well, end of conversation. And if you want to have more conversation, go see the therapist down the hall, which can be okay too. And, at least there's a therapist down the hall that they're having those conversations with, and we're all sort of working together as part of a mental health team. But the point is that doing mental health treatment is not just about focusing on psychopathology. And in that sense, I think that dealing with fear, which as you point out is not necessarily psychopathology.
Like if a train is barreling towards a patient, you're not going to do CBT to challenge that fear. You're going to get them out of the way of the train.
Right, but at the same time, if you can't get them out of the way of the train, and the train is coming, with enough time to converse, you may want to help the patient create an inventory of their lives, talk about what's meaningful, bring in some meaningful people, all sorts of things that could be aborted by a short-circuiting with euthanasia. So I want to move beyond psychopathology in our talk about what our role is, and I don't think I'm saying anything revolutionary. I'm describing things that I hope, at least in state-of-the-art good psychiatry, is what is the current practice. Yes, ma'am?
Hi there. I apologize, I missed the very beginning of your talk. You may have qualified this in your introduction or may not. I'm a medical ethicist and a clinical psychologist. And I guess your talk reminds me of a talk I heard by a critical care physician back in the early 70s who was aghast at the notion of withdrawing and withholding life support in the terminally ill. So my remark for now, although you are absolutely entitled to your perspective, it's an informed perspective, and I appreciate hearing your perspective. It's a very unbalanced perspective, I think, that you provided today. So for those who are interested in hearing about physician-aided dying in a more balanced and nuanced way, I would suggest that some of the learners in the room read some things on the HastingsCenterReport.org. Balance.
Okay, so fair enough, and I absolutely, as I said to you at the beginning, I have a point of view about this. So I'm not here to teach you about both sides, and I do invite you to maybe have another grand rounds with the doctor that just spoke to maybe hear a different perspective, and there is a dialogue about this. But most importantly, what I wanted you all to be able to see, specifically the core of what I presented to you today, is what is going on with psychiatric patients, what is the experience of countries that have had a lot more duration at this, and how, on the basis of the ethical principles that we support and talk about, our most sacred tropes, fairness, justice, parity, and so forth, how those things create what starts off as a circumscribed area, which my point of view is physicians shouldn't participate even in the terminally ill. And yes, that's one point of view, and I hope I've at least given you that side of the argument. But I think that holding it to that has been an impossibility in the nations that we see that have been at this, and even in our own states, like Oregon, who just have a slower trajectory getting to it. So we need to be aware of what's going on. We need to be prepared because this will happen. Those of us who are watching this closely and thinking about this really expect that eventually this meme of legalized physician suicide will continue to spread, that there will be more states, that there will be a precession to euthanasia, and that the good ethical arguments that we're making here, once the horse is out of the barn, will be unable to retain it from going to the further pastures of the non-terminally ill. And begin one of the things I didn't get into, there's a tremendous pushback on this from the disability community, because the disability community is trying to say what we're doing here is we're defining the concept of lives not worth living. And we feel very vulnerable in a society that is now returning to this concept of there are lives not worth living. And yes, we're now saying we're not going to take people's lives from them, they're going to take them themselves. But there is a number of people that have talked about, who live in these societies, the coercive, the subtle as well as strong coercive elements to consider the possibility that your life isn't worth living. I have a colleague whose father has a very significant chronic medical condition, and prior to euthanasia, he got a lot of sympathy and support from his friends, but subsequent to the passing of that law, his friends have changed their attitude and said to him, look, you could have euthanasia. In other words, quit your belly aching. There's a solution here. Maybe your life isn't worth living. So those are some of the things that the disability community is very worried about. So I think that, and my other main point here is that I think killing does not belong in the House of Medicine. Again, if society wants to set this up, let them do it across the street in the Department of Philosophy or at the law school.
Dr. Comrade, thank you very much. We do have that.
All right.
Thanks.